Patients with non-small cell lung cancer, which is non-squamous in histology, have tumour which either has activating mutations or without driver mutations. Those with driver mutations can have therapies which are targeted against it, which can be used and can often be highly active in switching off the function of that genetic aberration. In that setting, those patients with driver mutations often do well in the metastatic setting with very long, durable responses, good progression-free survival, which usually translates to long overall survival. By comparison, those patients without driver mutations, effectively the vast majority of those patients undergo chemotherapy and sometimes immunotherapy. And in the vast majority of patients, that overall survival can be somewhat limited. The percentage of patients with non-squamous, non-small cell lung cancer without driver mutations is variable depending on which study you read, but it's somewhere in the order of about 20% to 30%, sometimes even less than that, depending on the extent of tumour testing that has been done. The vast majority of patients with non-small cell lung cancer, which is non-squamous in histology, that have undergone genetic testing, have got driver mutations such as KRAS, ALK, EGFR, BRAF, ROS, HER2, and there are a smaller number of other variants that have been identified. But even when you put all of those together, there's usually on average of about 20, 25, sometimes 30% of patients that don't have driver mutations. In patients with advanced non-small cell lung cancer who lack a driver mutation, their treatment after failure of first-line treatment is really quite challenging. There's a huge unmet need here because the prognosis untreated is extremely poor, and the standard that we've had for many years, which is docetaxel chemotherapy, has really very minimal activity. It has lots of toxicities, including alopecia, high rates of febrile neutropenia, if not given primary GCSF prophylaxis, and for many patients, this just isn't optimal care.